Okay, my name is Bob Price. I'm the Chief Clinical Physicist at Fox Chase Cancer Center. And I've been asked to speak to you about radiation therapy physics at our center. We have 10 PhD physicists on staff, and at any one time, we have at least 3 medical physics residents in our CAMPEP approved medical physics resident program. We're all here to support the efforts of our physician colleagues in treating our cancer patients. So obviously I could talk for a great deal of time on many things, but I've tried to limit it to about 8 different sections that I will go over and show you things that you will be involved in and things that hopefully we can help you with. The first one would be advanced imaging for target delineation and treatment design, complex delivery techniques, hypofractionation, a big topic, advanced imaging for patient setup and target localization, brachytherapy, reirradiation, pulsed low dose rate, planning and delivery, and radiodynamic therapy. This one will be exclusive to Fox Chase. So for advanced imaging techniques for target delineation, we utilize multi-modalities. We use CT, MRI, spectroscopy, ultrasound, PET, many different imaging modalities to help you try to delineate the tumor or the target regions. And we will hopefully be able to show you how to utilize these modalities in a most advantageous ways. We have a dual energy 16 slice scanner within the department. We utilize this for many different reasons, using different modes to try to visualize tumors more effectively for artifact suppression, etc. We also do a great deal of 4-dimensional imaging. This is simply binning up our images as a function of the breathing cycle, meaning that if we take images at different phases of the breathing cycle, we can bin them up and then evaluate them accordingly. This may be turning the machine on at specific times of the breathing cycle, turning it off at others, correlating this to when the tumor is in a specific position. Or it may be just to help us acquire imaging to tell us what the total trajectory of a tumor is in a breathing state. We acquire 4D imaging in all of our thorax and all of our abdominal patients. So this is what this actually means. We will have a CTV, a GTV, and then a ITV and subsequent PTVs all generated as a function of the breathing cycle. From this information, we can acquire or build maximum intensity projections, average intensity projections. What do these actually mean? Where do we calculate dose? What type of scans? What scans do we put the normal structures on? What scans do we apply contrast to? When should we use different breath hold techniques like deep inspiration or end expiratory cycles? And how do these correlate with the daily cone beam CTs you'll be aligning your patients with? Hopefully we'll be able to help you with this. We have 2 MRI units within the department. We have a 1.5 Tesla MR simulator with HIFU for tumor ablation, as well as a newly acquired 3T magnet for simulation. And this is a very old slide. This one was taken off of one of our original CTs or MRs, but just to give you an idea of how much better you can see with the MR and the added advantage of soft tissue contrast. You can see here the prostate was delineated on CT, but here with MR. Much difference in target definition, so we're much more accurate, as well as we don't get the same artifact associated with image reconstruction from CT as when we're using MR. So we'll be able to see everything. So we utilize the MRs on many body sites. Well, complex delivery is obviously what we're going to do once you tell us what the target is. And by this, I mean intensity modulation. So that's often advantageous for us to utilize very, very complex intensity maps like the one shown here. But how can we create such a thing? Well, what we can do is look at any beam's eye view and break the intensity map up, or how much radiation is going through each individual beamlet. And in this case, I've defined it as 1 by 1 centimeters beamlets, just for demonstration purposes. How would we build such a thing? Well, we'd use the multi-leaf collimator that's attached to our linear accelerators. And if we do this from each beam trajectory, we're able to create very, very conformal and concave dose distributions to help us spare critical structures while delivering the dose that you would like. If we take this one step further, we can do the exact same thing while we're physically moving the gantry. So now we have MLCs moving, dose rate changing, and gantry changing all at the same time to form what's called volumetric modulated arc therapy. 100% of our head and neck service is now on this type of treatment. It's much faster, and very, very highly conformal dose distributions result from this. We've now treated over 13,000 IMRT and VMAT cases at Fox Chase. So hopefully we will teach you a great deal about these two modalities. Now, hypofractionation is a big topic for ASTRO as well as many other organizations. And this is where we decrease the number of fractions, but increase the dose per fraction, which requires us to decrease the total dose. Now, there's socioeconomic impacts from this, meaning that perhaps patients can't come for 40 fractions or 30 fractions. It might be advantageous for them to be able to come to fewer fractions. It may be cheaper in the long run for them to be able to afford the high quality treatments these can afford, assuming we get the same outcomes as we would from conventionally fractionated treatments. But there's also radiobiologic impacts. Some tumors respond better, we found, and others have found, if we give higher dose per fraction. But we need to adjust the total dose. We need to adjust the dose volume constraints for the organs at risk so that we can deliver these safely. We have now been doing hypofractionation since the early 2000s, and we have dose constraints for every body site, much experience in this region. We have actually a CyberKnife, which is basically an accelerator on a robotic arm that allows us to not only track the tumors, but we can also deliver SBRT or stereotactic body radiotherapy with this type of a system. Over 1/4 of our patients each year are treated with SBRT, either on conventional Linacs or on the CyberKnife. So we do a great deal of SBRT here. The advanced imaging techniques for treatment setup and target localization won't be just the cone beam CT or the orthogonal imaging that you would have read about, but we do interesting things like we implant beacons within the targets. In this case, the Calypso system, where we put radio transponders within a target, excite them, and then each one gives off a specific signal. And this array that you see in the right-hand side picks this up and associates the centroid, or the middle of all of the beacons, with the isocenter of the machine, and we can move the patient into the appropriate portions of the dose cloud very, very accurately. So this allows us to localize much more accurately for targets that actually move, in this case, the prostate. We also utilize breath hold techniques, and many have found that in this case, for the left-sided breasts, we want to make sure that we don't harm the patient by over-irradiating their heart. And we found that if we can just simply increase the distance between the heart and the posterior chest wall, then obviously we can decrease the dose to some of the critical structures. But how do we know the patient is actually in the same breath hold state each time? Well, we have what's called the Vision RT system here, and it's a topographical system that allows us to see many, many, many points in a speckle pattern along this surface of the patient and compare them to what was acquired during the simulation process. We can even ask the patient to take part in this. In this case, you can have them wear a goggle system, and they can breathe till their pattern falls within a certain set of parameters, or not in the parameters. Here would be what we would want. In this case, as I said, many patients wig while wearing the goggles, and they don't necessarily like this. So we use a small view screen for them and let them take part in this, and we find it's much more effective when they take active role in their management. We manually gate these types of treatments, and we even use this topographical system on non-breath hold patients for setup, because it's very, very accurate and very rapid. We have a large brachytherapy program at Fox Chase. We do approximately 170 to 200 HDR prostate deliveries per year. We have our own vault with a system in place within the department. They're all placed under ultrasound guided, transrectal ultrasound guided. You will be, when you're on the services, you'll be placing these needles and defining these targets on this ultrasound system. And we do real-time planning within the room. No need to go to CT. Everything's based on high resolution ultrasound. And so there's no change in a patient's body position. So it's very, very accurate. Our side effects are much better than they were with the SEED program. We haven't actually done a SEED case for prostate in a 6+ years now, almost exclusively HDR. We do mostly HDR for this and GYN. We do LDR here in the form of the Civisheet. This is a unidirectional palladium source, palladium 103, that has gold embedded on one side. And what that gold does is attenuates those low energy photons from coming out the other side. This is all embedded in a bioabsorbable substrate that is sewn into during surgery into the tumor region, and typically the tumor bed, and it decays with the source. So it goes away basically. Here you can see from the vendor on the right side, you can see the dose to the tumor. On the left side, where we'd had to go through the gold, very low dose. And this is where you would put the healthy critical structures. This is from one of our cases. This would have been a pelvic sidewall. And you can see the very low dose projecting this way. I think we've done a little over a dozen of these cases now. Reirradiation is a big topic for this center. We've just completed an invited paper saying how we perform this so that others can learn from this. The idea here being that every target, every tumor in your body, every structure in your body has a tolerance to radiation. But what happens when the radiation comes back? It may come back because it grew back in the same area, maybe an adjacent area. Tumor started to grow, or perhaps it's been enough time that our radiation actually caused a secondary malignancy. Whatever reason the tumor's back, the critical structures in those regions have dose volume limits. In this case, this patient was treated to 64.8 gray and 36 fractions in the early 1990s, but the tumor came back, and we would like to give another 60 gray and 30 fractions, but clearly our spinal cord dose would be exceeded here if we did this conventionally. So one of the things that we want to do is how much is safe. We like to use what's called the equivalent dose at 2 gray per fraction. This is based on the linear quadratic model, and it's basically just the dose that is biologically equivalent if we would have given the entire dose at 2 gray per fraction. The beautiful part is that the EQD2s are numerically added. You can add them linearly, and that the values that you get for limits are the same values that we normally see. If the cord limit is 50 gray, this is 50 gray. It's not some abstract number that doesn't mean anything clinically to us. So we feel that this is much safer, and we do like using this. What happens though when we can't just use the equivalent dose at 2 gray per fraction? We're unable to get enough dose in to help the patient. Well, we've come up with the folks at Madison, Wisconsin came up with what's called the pulse low dose rate technique. We took it and expanded it to the more advanced treatment techniques of IMRT and VMAT. So basically, we know, and others have found, that there's a dose rate effect. If the dose is low enough, the cells can repair during radiation, okay? So this is most pronounced at about 1 to 100 centigrade per minute. Also, at low doses, at very low doses, cells demonstrate hyperradiosensitivity. Okay, they're even more sensitive to the radiation than they would have been at a normal 2 gray per fraction. But as we start moving along this curve, this is the survival curve, we can see that we start getting what is called radio resistant. So we come back into a region where this is not helping us. After this, it fits the curve normally. We would like to take advantage of this. The dose at which repair is triggered in is higher in tumor cells than in normal cells. So this is exactly what we do with the pulse technique. The goal is to take advantage of that differential between the tumor and the normal tissue situation by using 0.2 gray pulses. The repair is triggered in the normal cells, but the tumor cells don't get better. Many tumors also demonstrate low dose hypersensitivity, as I had mentioned. And we deliver those 0.2 gray pulses every 3 minutes for an effective dose rate of 6.7 centigrade per minute. We can't physically turn the machines down that low. So what we actually do is, this is a little cartoon that shows this. If we were to give 2 gray normally, we'd give it at say 500 MU per minute, all very rapidly. But here we will give 20 centigrade in a 180-second cycle, or a 3-minute pulse. If we run out and we've given the number of monitor units associated with that 20 centigrade, you wait that standoff, it's called. And then after 180 seconds, you beam up the second one, then the third. It takes about 30 minutes. But what we find is we've had multiple IRB approved protocols that we're able to take critical structures well over their routine tolerances and help these patients, whereas previously they would not have been able to have reirradiation. Here's an example for an esophageal case. This was pre-treatment. This patient had had 50.4 gray with chemotherapy, 7 centimeter mass, and almost total dysphagia. 1 month after treating with 60 additional gray, he can swallow normally, no toxicity except for mild fatigue. So this worked out very, very well for him. So what we've come up with most recently is what's called radiodynamic therapy. Okay, some of our colleagues, we have colleagues in China and 2 affiliated hospitals that are actually doing this, and we have subsequently begun doing this. Photodynamic therapy has been around for about 100 years. What we know that if you have a tumor that grows on the surface and we can put a radiosensitizer on it topologically and shine specific light of specific wavelengths on it, the tumor will go away. The problem is most of our tumors don't grow on the surface, so we're unable to get to them and treat them with light. Light only penetrate up to, say, about 11 millimeters in tissue, so it doesn't help us with deep-seated tumors. But what we found is 2 interesting things. Some of these photosensitizers can be used as targeting agents. So we can give them to the patient orally or injection, and 10 to 20 times higher concentration in a tumor than normal tissue will result. If we can then just get the light to that region, we could in theory harm the targets. Well, we know that if we make a charged particle go faster than the speed of light and medium, we get this what's called blue light or Cherenkov light. So we can create this light directly in the cellular fluid, and so we're talking angstroms instead of millimeters. So the higher the energy, the more Cherenkov light we can get. So we have actually acquired a system that's actually 1990s technology. It's called a racetrack microtron. And in this case, we can produce a 45 MV accelerator. Now, back in the 90s, this was used for penetration. The higher the energy, the more penetration. We're not using that for this at all. We're giving very low dose, but very high production of Cherenkov radiation. And along with the appropriate drugs, we're thinking that we can help these patients in this mechanism, with this mechanism. So here you have the light and the photoactive drug, and we produce these reactive oxygen and species and free radicals. We can also initiate cellular apoptosis. If this happens in proximity to the mitochondria, we can kill the cells directly. So what they found, in our Chinese colleagues have found, here's one slide that'll just give a quick demonstration of this. As you can see here, before RDT, on this CT scan, this mass in the left hilar region, post RDT, gone away. Here we have a PET CT, very active, gone away. So they've treated about 3,000 patients like this. We have just recently started treating patients on an IRB approved protocol. And we're very, very hopeful that this will be a change for radiation therapy as a whole, because we can now treat patients that had no hope. These will be initially, they're all very late stage patients, and we may be able to get them, if not cured, get them to a point where they can undergo additional therapies, and we may be able to help them. So with that being said, I'm hopeful that you found this interesting and some things that you will get to be involved with if you come to Fox Chase Cancer Center. So thank you and take care.